A lot of people are asking questions, and today I'm going to try and answer some of the bigger ones. What you need to know, first of all, about that flesh-eating bacteria. Also, why 1 in 3 schools have air quality so bad it can make children sick. What to do about it. And what is the filthiest spot with the most germs in your workplace? We're going to get to those. But first, let's take a look under the microscope. You know, we're looking at this controversial new position from the U.S. Preventive Services Task Force, which says men should not be screened routinely with the PSA test. Now, as you probably know by now, it's a simple blood test, and it's the only screening test for prostate cancer, which is the second leading cause of cancer deaths in men. Now, the American Cancer Society supports these new guidelines, but many other groups do not. So I'm here today with Dr. Otis Brawley, you know him from the American Cancer Society, also Dr. Scott Miller, a urologist who says not screening could cost lives. We're going to get to that debate in just a moment, but first, I want to try and explain some of the reasoning behind these new recommendations. Basically, they say that more people could end up harmed by unneeded treatment after a worrisome PSA result than are saved by early detection. Now, we talk about these numbers a lot, but it's not an abstract problem. I want to bring in Dr. Jeffrey Stark. He's a pediatrician in Houston who last year became a prostate cancer patient himself. Welcome, Dr. Stark. Thanks for joining us. You know, as I said, there's real stories behind a lot of these numbers. You were concerned, as many men are, about prostate cancer. You had a family history. You wanted to get it checked out. So what happened after that?
Well, several years ago, I had a slight rise in my PSA from screening. And I had a biopsy done then, which showed everything was okay. I had more testing done after that and had, again, a very slight rise in my PSA. And the urologist wanted to do another biopsy, which I had done a year ago, February. And I got extremely sick. Even though I had antibiotics, I got septic, a severe bacterial infection with high fever, shaking, chills. My blood pressure went dangerously low. My circulation shut down, and I was hospitalized for 4 days here in Houston.
And you're okay now, obviously. I mean, that all resolved?
Yeah, I'm fine. Actually, I had a little heart rhythm problem afterwards as well, but now everything is fine. I don't have prostate cancer.
I want to get back to you in a second, Dr. Stark, but Dr. Miller, you hear a story like this, and obviously this is one case. There are lots of different cases. But what do you think as a urologist when you hear something like this? He got harmed, you know, potentially by this, by going through the biopsy, getting the infection, his heart problem, did not have prostate cancer. How big a concern is that to you?
Well, it's a big concern. I'm very concerned. I sympathize with Dr. Stark's position, his perspective on it, and I'm happy that he's fully recovered and happy that he doesn't have prostate cancer. But that is a complication of the biopsy. What the task force has put forward is that that would be a result, these types of complications are a result of the PSA blood testing, but it's clearly a complication of the biopsy.
What do you tell your patients in terms of when, at the beginning of the whole process, somebody comes in and they say, we're going to get a PSA test. How do you talk them through how that whole scenario could go for them?
Well, the first thing I tell them is what the PSA test is for. It's to screen for prostate cancer. It's not to diagnose prostate cancer. We need other tests to diagnose prostate cancer. The PSA blood test can vary depending on the patient's situation. So depending on whether they're old, young, what their risk factors are for prostate cancer will be one factor in terms of my recommending a biopsy subsequently.
Dr. Brawley, obviously your position on this, and you've written about this and talked about it quite a bit, and the American Cancer Society supports these new guidelines. What do you think the role of PSA test is? I mean, it sounds like people want to abolish it nearly completely.
We need to move screening into the physician-patient relationship, where physicians look at a particular patient and say, these are the known harms, these are the possible benefits. There are a lot of harms associated with it, but there may be some benefits. Do you want to get screened? And let the patient decide.
But look, I mean, look, I'm a doctor and I'd have a hard time answering that question. I've read all these studies. How's a patient supposed to make that decision?
Well, I think the most important thing is there's been so much, you should get a prostate screen without actually explaining to people that there are harms out there.
So what would you say to them? I mean, so you asked Dr. Miller the same question. So let's say I'm getting a test in your office. I know you're not a urologist, but let's just say I am. What would you tell me?
Well, actually, I do practice general internal medicine. I do think that there is a point in time where the patient can legitimately say, Doc, I can't make a decision. Can you help me, or can you make the decision for me? And I think the doc should weigh the patient's concerns, weigh the patient's risk factors, also inform the patient that we don't really have good studies to show that this saves lives.
Well, I disagree. I think there is evidence in several studies that it does save tests. I'm not going to quote these statistics, but there has been a 40% reduction in prostate cancer deaths since the advent of PSA.
I've heard you say that, look, if you have symptoms, you should get tested. What are symptoms?
Yeah. Any man who has urinary problems like benign prostatic hyperplasia, I think it's very reasonable to do the test there.
But most people develop that.
And it may be reasonable to do the test.
But I don't mean to keep interrupting you. So if you say symptoms are some of these urinary symptoms, and most men will develop it, aren't you just testing them now late?
Not necessarily. Indeed, there's some studies to suggest that that is not the case, that you can still have early detection when using the test.
I bring it up because, again, these are conversations men have, and they say, look, I'm going to develop the symptoms which would lead to PSA testing, so you're just saying, wait till I'm more advanced in age to get the testing, and that could potentially be also letting cancer run amok. Yeah. But let me let Dr. Miller weigh in. What are you going to do now? How does this affect your practice?
May I respond to the symptom question? I actually disagree. I do think patients that have symptoms need to be evaluated for many reasons, and probably including a PSA blood test. But number one, prostate cancer often is not curable once you have symptoms from the prostate cancer.
Keep in mind, all of us agree, I think you will agree with this, that men who are over the age of 50, especially, should know the known harms associated with PSA screening and treatment. It's really not the screen, it's the treatment associated with the screen that causes the harms, along with the potential benefits.
Dr. Stark, you've been listening in to this conversation. Look, I mean, would you do it again, given all that you know now and all that you've just heard?
I teach residents and students, and it reinforced the principle that I teach them, and that is when a person without significant risk factors is screened with any kind of test, a positive result is actually much more likely to be a false positive. And if that false positive leads to an invasive treatment or procedure being done, it can lead to consequences. And unfortunately, in my case, those consequences occurred.
Well, I'm glad you're doing well, Dr. Stark. I hope we tried to make this a little bit clearer for people out there. It is confusing, but it's, as I was saying to Dr. Brawley and Dr. Miller ahead of time, it's fun to dive into these issues every now and then. Thanks for joining us.
Thank you for the opportunity.
We'll keep talking about it, I think. But coming up, what